Good morning. My name is Samantha Beyer, and today I will be presenting my evidence-based practice project on nurse staffing shortages and the impact of acuity-based staffing models on patient safety outcomes in intensive care units. This project was completed for my advanced research and evidence-based practice course. Nurse staffing is a topic I am personally and professionally passionate about because I have seen firsthand how workload directly affects patient outcomes, nurse burnout, and overall quality of care. So, my identification of my problem, my PICO question asks, in hospitalized adult ICU patients, how does the implementation of an acuity-based nursing staff model compared to fixed staffing ratios affect patient safety outcomes, including falls, medication errors, and healthcare associated infections within 6 months? So, this question was developed after reviewing literature showing that fixed ratios do not always reflect real time patient complexity. Two patients may technically count as a 2-to-1 assignment, but their acuity can vary drastically. The goal of the project is to explore whether staffing based on patient complexity rather than just numbers leads to improved safety outcomes. So continuing on to the identification of the problem, this is kind of shows the evidence of impact. The literature clearly demonstrates that staffing shortages significantly impact patient safety and quality of care. Studies consistently link inadequate nurse staffing to increased mortality, adverse events, and missed nursing care. So, for example, higher staffing levels have been associated with a 14% reduction in mortality risk. We also see some system level type implications. Oklahoma has approximately 7.5 nurses per 1,000 residents. And then I also saw that nationally, over 100,000 nurses left the workforce in 2021. Financially, staffing shortages have contributed to over $117 million in increased patient costs due to prolonged hospital stays. This is not only a workforce issue, but it is a patient safety and healthcare sustainability issue as well. So, to review the literature, there are 4 themes here that I've identified after conducting the comprehensive literature review. So, first, increased mortality. A second would be missed nursing care, like delay in patient education, ambulation, and reassessment. Third would be nurse sensitive adverse events, including falls, medication errors, and pressure injuries. And fourth, healthcare associated infections. These would be things like CAUTIs, CLABSIs, and surgical site infections. Across multiple studies, there was consistent evidence that staffing shortages correlate with negative patient outcomes. So these themes reinforce the need for evidence-based staffing strategies rather than just a set ratio. So this is a mortality graph. It's a visual that demonstrates the relationship between nurse workload and patient mortality. So as nurse to patient ratios increase from 4-to-1 all the way to 7-to-1 on some med-surg floors, mortality risk rises significantly. This highlights an important concept that workload matters. When nurses are stretched too thin, surveillance decreases, early warning signs may be missed, and timely interventions are delayed. This slide helps translate research findings into something visually understandable. Safe ratios are directly tied to patient survival. So some policy recommendations. My goal is to try to implement an acuity-based staffing. because based on the evidence, I recommend transitioning from that fixed nursing ratio to an acuity-based staffing model. Acuity-based staffing uses validated scoring tools to measure patient complexity and adjust assignments accordingly. So some key concepts to include, we want to implement a validating acuity tool, adjust staffing based on real-time patient needs, maintaining a minimum safety floor, allow charge nurses input. I think that's very important, and integrating tracking within the electronic record. Research supports that staffing based on acuity improves patient safety and reduces adverse events while promoting sustainable nurse practices. So this is still kind of on the recommendations, but this is talking about the evaluation measures. So to evaluate the effectiveness of this practice change, both process and outcome measures should be monitored. So for the process measures, those include percentage of shifts meeting acuity targets, RN workload scores, overtime hours, nurse turnover, staff satisfaction, reports of missed care. And then on this other side here, we have patient outcome measures. This includes risk adjusted mortality, falls with injury, pressure injuries, and medication errors. Also think about the CLABSIs, CODIs, and ventilator type infections. This dual approach ensures we measure both nurse experience and patient outcomes. So this is kind of a before and after graph. So this line graph represents projected trends before and after implementing the acuity-based staffing model. Following implementation, we would expect gradual reduction in mortality, falls with injuries, and healthcare-associated infections over a 3 to 12-month period. While this example is kind of conceptual, literature supports that measurable improvements often become more evident after sustained implementation. So the key takeaway is that staffing reform is not an overnight solution, but it's a long-term kind of tracking that shows meaningful impact, right? So let's go down here. This is kind of suggestions for further study. Although evidence supports, acuity-based models, more high-level research is needed. Randomized controlled trials comparing fixed ratios and acuity-based models would strengthen the evidence base. Experimental and interrupted time series studies would be helpful. Mixed methods research is also important because you want to explore nurse perception of workload equity and moral distress, right? Future research should include multi-hospital studies, cost effectiveness analysis, standardized acuity tools, and longitudinal tracking of at least 12 to 24 months. It might take a year or two to really see the changes. Long-term sustainability and standardization are critical. Without standardized acuity measurement tools, implementation varies widely across institutions. So further research should focus on developing consistent frameworks that can really be adapted nationally to all the different hospitals. So these are my references. These reflect kind of the peer-reviewed literature supporting this project. Together, they provide strong evidence that can help, support this acuity-based staffing model. And that is the end. I just want to include, in conclusion, just say that nurse staffing shortages are not just workforce challenges; they are patient safety risks. The evidence consistently demonstrates that staffing levels influence mortality, they influence adverse events, missed care, healthcare type infections. Um, and so I think transitioning to an acuity-based model will help, this stuff improve and maybe even resolve. We have a responsibility to advocate for systems that protect both patients and, the nursing workforce. So thank you for your time.